He's a neurologist. He studied medicine at the Karolinska Institute in Stockholm in Sweden and trained in neurology at the Karolinska University Hospital. He has a special interest in cerebrovascular neurology, traumatic brain injury, neurorehabilitation, MS, and the post-polio syndrome, and he published in the Lancet Neurology on the post-polio syndrome. His topic today is stroke and atrial fibrillation on the delicate matter of introducing and reintroducing anticoagulation. I should say that George has great experience in stroke. He's one of the first individuals, if not the first, to do thrombolysis in Cyprus in stroke, and we are very keen to listen to what he has to say. If people have any questions on his lectures, they can raise their hand and their questions will be answered at the end of the lecture. Without any further ado, perhaps George Kaponides can start the lecture.
Thank you, Theodoros. I hope I'm being heard. Let me see if I can get the slides started. Please be able to see this by now. First of all, I would like to thank you for attending, given today's dramatic and tragic news from Ukraine. So I hope this will deviate your attention for a while from what is going on in Ukraine. So the topic for today's lecture is stroke and atrial fibrillation. We will be discussing the connection between atrial fibrillation and anticoagulation, and of course we will be discussing some clinical situations in regards to intracerebral hemorrhage, intracerebral bleeds, as well as ischemic stroke and transient ischemic attacks. Let's start with the basics. I understand that most of our listeners, our viewers are medical students, colleagues, but some may not be medically trained. So the definition of stroke according to the World Health Organization is the cerebrovascular event that presented itself with rapid onset of focal or global cerebral dysfunction or leading to death, where the duration is 24 hours or longer, and the cause, of course, is vascular. This is a clinical definition, and as we always discuss with our students, the clinical definition does not say anything about the type of stroke, whether it's ischemic or hemorrhagic. It doesn't say anything about the pathology or for the mechanism behind it. Well, if it's embolic, for example, that the clot is formed in one part of the body and it's traveling with the bloodstream to another part of the body, or whether it's a question of local atherosclerosis. This definition was coined back in 1970 and regarded to be obsolete nowadays because by no means do we will wait 24 hours to call it a stroke, but by means of imaging, we do make a decision with the presentation whether this is a stroke or not. So again, most of the strokes would be ischemic. 80% of all strokes are ischemic. Usually that would be an arterial occlusion that could be due to embolism. There could be a cardiac sort of embolism, often atrial fibrillation. And here is the connection. One of the connections, stroke. It could be due to large vessel disease, often carotid stenosis, for example. A plaque may be formed on the carotid artery, and this plaque may be so severe, or the plaque may be damaged so that there is adhesion of platelets on the surface, causing formation of clots that will be traveling with the bloodstream to embolize distally. Or it could be, again, due to small vessel disease, which will be causing lacunar infarct. The mechanism here is thought to be different. But above all, it could be a combination of the above causes. or it could be even cryptogenic. It could be unclear. In these cases, cryptogenic strokes, at least 1 in 5, is considered to be due to atrial fibrillation. More rarely, it could be a question of venous occlusion, where a venous cerebral sinus thrombosis could be the cause of the stroke. This is a rare condition. It's been a lot of the news during the past 2 years following the AstraZeneca complications causing cerebral sinus thrombosis, although still that was extremely rare. 1 out of 5, 20% of all strokes, 1 out of 5 will be hemorrhagic, and the most common cause there is hypertension, high blood pressure, or cerebral amyloid angiopathy. Less common are other causes, but I will not go into that as to save some time. A few words about atrial fibrillation. Atrial fibrillation is a supraventricular tachyarrhythmia that is causing an irregular rhythm, with secondary fibrillating atria with a frequency up to 300 to 600 beats per minute. And this is causing an erratic but rapid ventricular response of 100 to 180 beats per minute. This is characteristic on an ECG strip, characteristic ECG strip showing this irregular rhythm with variable R2R intervals. The peaks are the R waves. So the irregular R waves, the irregular R2R intervals with no discernible P wave before each QRS complex is the definition of AF. Of course, you need to have a sequence that is lasting at least 30 seconds or more to be able to call it AF. I will say a few words about the management of AF because a cornerstone of in the management of AF in many studies and in many throughout the years has been anticoagulation. So as you can see, you have different types of AS. You have silent or subclinical AFs, but you may have also paroxysmal, persistent, or permanent AF of different duration. Different approaches in regards to managing patients with atrial fibrillation. But the basic cornerstone of the treatment is always anticoagulation. There are some prerequisites for that. We will look into it. Of course, rate and rhythm control is also a crucial aspect in managing AF. Use of antiarrhythmic drugs. For some patients, RF ablation or cardioversion can also be the methods of treating and managing the condition. Also, managing the so-called underlying disease, treatment of the underlying, the so-called upstream therapy is crucial and can be part of this treatment regime. We don't want to go into this in great detail because this is not really the topic. I would like to orientate you, and before we focus on the main topic of this talk. Just one slide on the various anticoagulation choices available. This is more or less what is being used, and this is the clotting pathway where you can see that the old time reliable choice of warfarin has a key role to play addressing factor 7, 9, 10 as well as prothrombin. The NOACs are addressing the factor 10A, 4 of the NOACs, whereas the other 2 are addressing the thrombin. So these are called direct thrombin inhibitors and the factor 10 inhibitors, but the overall name for both is the new oral anticoagulant, NOACs, as we call it in short. There are a number of studies. I'm sure you cannot really read this. My point here is to show that there are a number of studies connecting the efficacy of anticoagulation as secondary, as primary prevention for patients with atrial fibrillation, primary prevention of stroke, which is why, as I said earlier, anticoagulation is a cornerstone for treatment of atrial fibrillation. So I will focus now and discuss hemorrhagic management of patients with hemorrhagic stroke, because there are many situations that may arrive in this setting. And before we proceed to discuss patients and clinical scenarios, I would like to clarify that in many studies, there is the term intracranial hemorrhage, and intracranial hemorrhage mentioned in some studies, but not all. Other studies are also discussing intracerebral hemorrhages. And since 2/3 of all NOAC-related intracranial bleeds are intracerebral and the rest are subdural, I will be referring to the term ICH as intracerebral hemorrhage. So I am asking for your understanding as not to make things complicated. So most of the times when we say ICH, we will mean intracerebral hemorrhage. However, subdural hematomas or epidural, for that matter, may be the case. Not so often subarachnoid hemorrhage. So these are the here we go. Causes of intracerebral hemorrhages. The most common cause for all intracerebral hemorrhages is hypertension. It usually will be giving deep bleeds that are located in the basal ganglia area, but not only. You could have deep bleeds elsewhere. Second most common cause would be cerebral amyloid angiopathy, that often is causing lobar bleeds. These are bleeds that are located superficially in the cortex. Other causes would be AVM, again causing lobar bleeds. AVM stands for arteriovenous malformation, that's a vascular malformation. Brain tumors can also bleed, either primary brain tumors or secondary metastatic tumors from different types, especially melanomas or renal cell carcinomas can bleed easily. Cavernomas, that's vascular malformations, again, that are due to malformations on the venous side of circulation. Cerebral sinus thrombosis causing superficial hemorrhagic infarcts. That's cortical hemorrhage, or that's cortical infarct with a hemorrhagic component. And of course, different coagulation disorders and anticoagulation may be causing intracerebral hemorrhages, or different drugs, especially drugs that may be causing spikes in the blood pressure, may be causing cerebral bleeds. A special case is the case of the hemorrhagic transformation of an infarct. That's an ischemic stroke, that's an infarct to start with, but in some cases, this infarct may be transforming with a hemorrhagic component, so there is a bleed around the infarct area. This is a study from the Swedish National Stroke Registry for the full year of 2020. This shows the proportion of patients on anticoagulation in Sweden upon admission following intracerebral hemorrhage. And this is to show here that nowadays almost 25% of all patients admitted were on some type of anticoagulation. So a large proportion of the intracerebral bleeds are related to anticoagulation. And as you can see here, since 2018 and onwards, more patients were on NOAC than on warfarin. So the presence of intracerebral hemorrhage under treatment with warfarin was 1.5 times higher compared to NOACs at this point in time. This is again to show that the NOACs seem to be more safe effective in preventing strokes compared to warfarin. On this side, favors not. I believe this slide is slightly faded. I'm very sorry for that. There is a slight benefit for patients being on NOAC rather than warfarin when it comes to intracerebral hemorrhage. It's the other way around when it comes to gastrointestinal bleeds. That warfarin seems to be favorable for that. So let's discuss a clinical case. This is a type of patient that we often see. 72-year-old male here with atrial fibrillation and hypertension that has sudden onset of symptoms. And of course, when imaging is performed, thalamic stroke is noticed. The white area here is the blood depicted as white on CT scan. And the question here is how to proceed, how to manage the patient in this scenario. Again, being Swedish trained, I usually have a look on what my colleagues, my former colleagues in Sweden are doing. And according to the Swedish National Guidelines for Stroke, the intracerebral hemorrhage and AF introducing or reintroducing oral anticoagulation is actually a research thing, and there is no clear guidance on this. So there are many ongoing studies at this point in time, which of course is very frustrating because we need to deal with the patient anyhow. So we have to look further. And one very good study on this case was some information coming out of this study by Brønum Nielsen and colleagues that was published back in 2015, showing that the risk for stroke or systemic embolism among survivors with an intracerebral hemorrhage or with atrial fibrillation is significantly increased in the first 90 days following intracerebral hemorrhage. So this, again, it does not help us in deciding how to manage the patient, but we know that these patients are at risk, so we need to find the optimum time for introducing or reintroducing, to be more correct, reintroducing treatment. The European Stroke Organization guidelines published in 2019 state that in patients who had intracerebral hemorrhage, restarting oral anticoagulation can be considered after careful weighing of risks and benefits. That was a Delphi panel, and all experts participating in the Delphi panel agree on this. So again, we know that people, these patients should be treated, but we still don't know when. And again, there is more need for more guidance, and thankfully the European Society of Cardiology guidelines from 2020 has been shedding some light in regards to this, stating that patients with atrial fibrillation at high risk of ischemic stroke should be considered following consultation with a neurologist or a stroke specialist if the bleeding is trauma-related or if it's acute spontaneous, where you may consider the risks and benefits. However, the location of the bleed, if it's a deep bleed, for example, that is due to hypertension, where there is no imaging evidence of cerebral amyloid angiopathy with microbleeds, we will be getting to that in a short while. These patients should be considered to start, but again, there is not enough information on when this should happen. So the treatment decision requires a multidisciplinary approach from both cardiologists, stroke specialists, neurosurgeons, but also the patient and their family, because there is a risk, and the patient and their family should be informed about this risk. A meta-analysis of 7 observational studies of patients with atrial fibrillation who survived an intracerebral hemorrhage show there is a benefit in preventing stroke if they are treated again with turmarinics, with warfarin, although the risk for recurrent intracerebral hemorrhage is increased. Whereas, of course, as expected, the risk for ischemic stroke is increased if for the patients who were not treated at all, 7.3 compared to 3.2 for the patients treated with coumarin. So the timing for starting anticoagulation following bleed is based on SCATS data, but what seems to be reasonable is 4 to 8 weeks, and this time window is not taken out of thin air. This is the time it usually takes for the hemorrhage to be absorbed. NOACs, again, there are several studies, several papers confirming this, especially when it comes to NOACs, as Steffel has published in the European Heart Journal in 2018. They may be restarted during this period of 4 to 8 weeks if the individual risk for cardioembolic stroke is considered to be high and the risk of recurrent intracerebral hemorrhage is considered to be low. By that, again, we are thinking about the typical case of basal ganglia hemorrhage due to hypertension. Also, Nias Ahmed from Karolinska has published at the European Stroke Journal in 2018 that the reinitiation of oral anticoagulation in non-valvular AF should be, as mentioned, in the period of 4 to 8 weeks from start, from first bleeding, especially if these patients are not of high risk. That is, if they are not patients with suspicion of cerebral amyloid angiopathy that have uncontrolled hypertension or cortical superficial siderosis or multiple lobar cerebral microbleeds. We will be getting to that very shortly in discussing these two signs of cerebral amyloid angiopathy. Also, severe microangiopathy in the white matter that would be presumed, is usually presumed to be of vascular origin, is a warning sign. These patients are again at high risk for bleeding and or having cerebral amyloid angiopathy. The risk factors for bleeding on oral anticoagulation and also for antiplatelet, for that matter, are known. And of course, you have the modifiable risks such as alcohol intake or hypertension or use of concomitant use of platelets, aspirin, clopidogrel, or anti-inflammatory medication. But also one notable modifiable risk is actually the bridging therapy with heparin that has been used for many years. This has been shown to be a risk factor. The target INR for these patients, if they are on coumarinic, is between 2 and 3. And of course, the dose should be correct and according to guidelines, guided by the patient's age and the kidney function. The non-modifiable risk factors are, of course, the age, above the age of 65, previous major bleed, renal impairment, malignancy of any kind, some genetic factors as PYP2P9 polymorphism, previous strokes, or diabetes, of course, as well as dementia of any kind. The bleeding risk can, in essence, be reduced if the blood pressure is closely monitored and managed. So this is one of the main modifiable things that patients can actually do, and we as doctors can help these patients by keeping an eye on their blood pressure. Simple and effective. So let's go back to our patients and how to manage these. Well, as already said, we should wait 4 to 8 weeks for this. A small bleed like this usually is absorbed within 4 weeks, and this following the weight, it can be discussed whether a control CT should be done. In the guidelines, actually, there is no need for a control CT, but if there is any suspicion, if there is any clinical worsening of the patient's condition, then yes, a control CT should be performed before reintroducing anticoagulation under the term, of course, that close hypertension control, close blood pressure monitoring is in place. Please remember this slide, the location of this image, because now we will be switching to discuss case number 2, which is a 70-year-old woman with atrial fibrillation and diabetes, and has this very large superficial bleed. So this is a cortical bleed, a subcortical bleed. It's not a deep bleed, this is a lobar bleed. And this is typical of something different. So this is not the typical case of the patient who has a hemorrhage due to hypertension. So this is the case where we should suspect cerebral amyloid angiopathy. This is the same amyloid that we see in Alzheimer's. It's the beta amyloid that we see in Alzheimer's, but here the position is in the tunica, media, and adventitia. It's in the between the second and third layer of the blood vessels. Therefore, this is causing fragility of the blood vessels, and they may rupture very easily, therefore causing hemorrhage. Typical for these patients that there are signs on scans, and the two signs that we usually look for is microbleeds and cortical hemosiderosis, that's long-standing bleeding on MRI, and this indicates a very high risk for starting anticoagulation. So as you can see on this image, this slide here, the red arrows point at the dark spots in the periphery, and these are the microbleeds that are seen on the gradient echo sequences and the SWI sequences of MRI. These are to start sequences that are typical, and these patients we should be very careful in anticoagulating. Superficial siderosis, this is again what we see. The arrows, the white arrows, show these dark lines again in the cortex. These are typical for superficial siderosis, which is a sign of cerebral amyloid angiopathy. So if we have these signs, we know that cerebral amyloid angiopathy, unfortunately, this is an indirect way of making the diagnosis of cerebral amyloid angiopathy. Otherwise, brain biopsy or autopsy, in which case it would be too late for the patient to make this diagnosis. So if you see these on the MRI and have a suspicion of cerebral amyloid angiopathy, then this patient should not be treated. As already mentioned, yes, this patient should not be treated. So we say probable because, again, the diagnosis is either made post-mortem or with a brain biopsy, which is not what we usually do. So the MRI scan is what is guiding us making the diagnosis. A few words of what are our options if we cannot give oral anticoagulation. The one of the procedure that is possible is the so-called left atrial appendage occlusion. And before proceeding in explaining what this procedure is, let me say that a typical location for the accumulation of thrombi of clots in the left atrium is the LA appendage, left atrial appendage. So this is one way of addressing the issue by inserting a device. There are several devices that were developed in order to occlude this cavity in the left atrium, the appendage, and this is done endoscopically by introducing a catheter into the usually is the right femoral vein. So it's from the venous side of the circulation reaching the right atrium and then puncturing through the septum, the atrial septum, crossing over onto the left side of the heart and introducing this device into the appendage. And when this device is expanded into the appendage, then there is no longer a place for the clots to be formed. So this minimizes the risk for embolization from the LA appendage. So left atrial appendage occlusion is a method that was has been around for more than 15 years now, but still it's not fully evaluated and it's not a fully acceptable method that is reserved for certain patients. Excuse me. This is one other different device, but it's the same method. This is the Amplatzer amulet device, sorry. And again, it's introduced with the same way. And of course, it's the aim is to occlude the LA appendage here that is where the clots are accumulated. So I looked into, again, the Swedish guidelines for this. And this is a very interesting scenario. The cardiac care guidelines from 2018 consider this an option, 5 to 10 scale. That means this is a moderate evidence or not enough evidence, sufficient scientific evidence for effect, but it's recommended on a scale 5 out of 10 because there are no other options available. So this is very interesting. These are the guidelines for cardiac care. However, the guidelines for stroke care from the same authority actually say that if you have a patient with intracerebral hemorrhage and they have inserting left, occluding the left atrium appendage is still under research. It's not yet clear, and actually there are studies ongoing both in Sweden and elsewhere. The stroke flow study in Sweden, but even elsewhere, they are being underway for establishing whether this might be an option for some special cases. The European Stroke Organization guidelines show that say that there is no way you can make a recommendation whether left atrial appendage occlusion should be preferred over long-term anticoagulation with warfarin. And again, this was a Delphi panel, and all experts agreed on that. But left atrial appendage occlusion should be considered in some patients with as an alternative to lifelong oral anticoagulation after carefully weighing the risks and benefits. So I understand that this is not a satisfactory answer for clinicians. However, each patient is different and the circumstances should be weighed in, and the patient's families and the patient themselves, they should be informed about how to proceed, and if available, offer this as an alternative. hopefully in a year's time there will be more information from the ongoing trials, and this subject will be clearing up. This is an algorithm that can be used in managing patients who have a bleed, an intracranial bleed, and are taking oral anticoagulation. And if there is there is a contraindication for oral anticoagulation, as you can see, is class 2B evidence LAA occlusion, or no treatment at all. Actually, there is no evidence for that. Or if there is reason for withholding anticoagulation, then again, it's a cortical bleed suggestive of cerebral amyloid angiopathy, or multiple microbleeds, again, suggesting the same diagnosis, cerebral amyloid angiopathy, then there is a reason to hold oral anticoagulation. Otherwise, if the basal ganglia bleed with hypertension, then when the bleeding has been absorbed, patients should be receiving again treatment with oral anticoagulation after 4 to 8 weeks. Mind you, in the Hendricks and the colleagues in the guidelines of 2020 suggest that the period for reintroduction could be shortened to 2 to 4 weeks. But most other guidelines and studies suggest 4 to 8 weeks as being the time frame for reintroducing them. This is what I mentioned just about Hendricks suggesting 2 to 4 weeks instead of 2. There are different algorithms over this, but the principle is what we mentioned before, and of course keeping an eye, looking at the modifiable risk factors, especially when it comes to managing blood pressure, managing LDL, and also managing alcohol intake. Okay, we will switch over now to discussing ischemic stroke, and as already mentioned, this is far more common. Ischemic stroke is far more common. Arterial occlusion is the norm, and as you can see, as we already mentioned before, atrial fibrillation can either be the source of embolism, or even in cryptogenic stroke, 1 out of 5 would be having atrial fibrillation. So, of course, atrial fibrillation is not the sole cardiac source of embolism. Other conditions in the heart may be causing embolism. For example, a recent myocardial infarction, less than 3 months, is a potential source of embolism. Thrombus in the left atrium, congestive dilated cardiomyopathy with a low ejection fraction of less than 35%, mitral stenosis, myxoma in the ventricles, or mechanical heart valve, or endocarditis for that matter, are also other cardiac sources of embolism. But our topic is atrial fibrillation, so we will be discussing this. And as already mentioned, the LA appendage thrombosis is what is usually happening. But also it has been shown by noteworthy in a publication in 2019 Circulation Journal that AF on its own is a risk marker. So it doesn't necessarily have it's causing the stroke, but it can be considered a risk marker for ischemic stroke on its own. One of the difficulties in diagnosing atrial fibrillation is if it is paroxysmal. Nowadays, there are many different devices, even implantable devices that can pick up atrial fibrillation, but also wearables such as certain iWatches or similar devices can detect atrial fibrillation, and this is very helpful, of course. it's crucial to be able to document the AF. We as clinicians very often suspect that the stroke, the ischemic stroke, is due to AF because of the distribution of the infarct, usually affecting both anterior and posterior circulation, or maybe affecting both hemispheres. That would be implying that the clot has been breaking up and scattering. But this is not enough evidence, at least not yet. Imaging evidence is not enough. You need to be able to document it on an ECG strip or on a device in order to be able to proceed producing anticoagulation. So this is where these new technologies are coming in, and this is very helpful in detecting cryptogenic or paroxysmal or subclinical AF. It's reasonable to discuss the appearance of subclinical AF because if you detect it early and given the patients have intermediate or high risk, and that is the CHA2DS2-VASc score that is guiding us to what is intermediate or high risk. The CHA2DS2-VASc score is a score for any thromboembolic event due to AF within a year. It's given as a percentage. We will be having an example very shortly about that. And given that the appearance of AS, the gray area is actually what you see here, patients with intermediary risk, but with high subclinical AF burden. And the subclinical AF burden has to do with the duration and the frequency of appearance of the episodes of AF. Otherwise, if it's mild or if it's severe, then the decision to treat is much easier. So this is our third case. It's a 72-year-old male with atrial fibrillation, hypertension, and diabetes that was admitted at 6 hours from onset with very mild symptoms. As you can see, this is a cortical infarct. This is a diffusion-weighted imaging on MRI. So this was not a candidate for thrombolysis, partly because of the late appearance at the hospital, but also because of the low NIH stroke scale score. That was 3. There is a cutoff of 5. So this patient has not undergone thrombolysis or thrombectomy. There were no indications for that. But the question again here is how to manage. What should this patient have? This is an ischemic stroke. Remember, patient is already having AF and hypertension. Male sex is a risk factor again, and this is the CHA2DS2-VASc. So for each of these risk factors, congestive heart failure, hypertension, age equal or higher than 75, if the patient has diabetes, previous history of stroke or TIA, vascular disease, age between 65 to 74 gives 1 point, and male, female sex gives 1, male sex gives 2. So maximum score is 9. For our patient, the CHA2DS2-VASc score was 5. That means that the risk for a stroke, per yearly risk for stroke is 6.7. So for our patient, it's 6.7, which of course says that if this patient is not treated, there is a high likelihood for having another thromboembolic event or another stroke. There is, of course, a better scoring system than the CHA2DS2-VASc score. That's the ABC score that was developed by Oldgren in Uppsala. And here, the ABC stands for age, biomarker, and clinical history. high age, the appearance of N-terminal B-type natriuretic peptide and high affinity troponin T, as well as previous history of stroke, seems to be a better predictor than the CHA2DS2VAS score. The problem is that we don't have laboratories analyzing N-terminal B-type natriuretic peptide. But this could be used as a better predictor for stroke. This is something to keep in mind. So we delved again, took a look at the national guidelines in Sweden for the cardiac care, and of course the AF. The increased risk for stroke is one for men and two for women. The recommendation for this case is use NOACs and not warfarin. And again, the motivation is that the condition has low to moderate difficulty, and the recommended action has a good effect on the outcomes, and the risk for bleeding is equal or lower compared to vitamin K antagonists, that would be warfarin. So NOACs are preferred for this reason, and is actually the reason for the likelihood for bleeding. This slide again is from the most recent brief summary from the Swedish Stroke Registry, showing that nowadays almost 80% of all patients are treated with anticoagulation. If they have been diagnosed atrial fibrillation. So this is a good amount. If you compare, as you can see, the increase has started from 20, respectively 50%, depending, of course, on the age of patient. One of the complications we already mentioned is, of course, the appearance of hemorrhagic transformation. 10 to 40% of strokes will be converting will have a hemorrhagic component on day 2 to 4 when checked with a CT scan. There is an increased risk for hemorrhagic transformation if recanalization therapy is delayed, and that would be thrombolysis or thrombectomy. So this is actually the reason we do not proceed with thrombolysis after the time window of 4.5 hours, because we know that these infarcts tend to transform if we thrombolyze them. Especially high risk for hemorrhagic transformation is large infarcts. So this is also something to be considered. The Hasbled score is also used as a way of predicting the risk for hemorrhage, for complications, bleeding complications in patients with on oral anticoagulation. And as you can see, it's obvious that a very low risk if for a bleeding if the patient has not on a blood thinner, but the stroke risk is high for hemorrhage is high if they are taking blood thinners. Of course, ischemic stroke can be high for that. Let's go through this algorithm, whereas the crucial age of 65 is mentioned. If there is non-valvular AF, if it's valvular AF, then it's vitamin K. So this is quite straightforward. But non-valvular AF in a patient who is younger than the age of 65, then actually no antithrombotic therapy could be considered. Whereas if the CHA2DS2VAS score is more than 2, then use of NOACs, or if it's 1, again, NOACs could be used. And vitamin antagonist warfarin is an alternative for these patients. There are more elaborate flowcharts in managing these patients, and we'll be getting to that very shortly. Noteworthy, please, that 16% of patients with ischemic stroke admitted were actually on anticoagulation. Again, this is data from the Swedish Stroke Registry. And in Sweden, the distribution was 4% on warfarin and 12% on NOAC. So even patients who are actually treated do get a stroke, an ischemic stroke. So that means even these patients are at risk for another stroke. Let's discuss the our third case here. So this is a 77-year-old woman with atrial fibrillation, hypertension, cardiac failure of the mild type, previous lacunar stroke with a right-sided weakness, now has symptoms from her left side of the body. She was thrombolized, but symptoms remain. The NIHSS 7, so this is not bad because it's a large infarct. And the question here is how to manage. Well, again, we do score her with the CHATSA score, and the CHATSA score 7 is 9.6% per year. So the risk for a new event is 9.6%, which is quite high. 0.5 to 1.3% risk per day for a new stroke patient within the first 2 weeks following an ischemic stroke. So what seems to matter here is whether the ischemic area is large, the patient's age, and of course, if the left atrium is enlarged, or if there is appearance of thrombi in the left ventricle. These patients are at risk for hemorrhagic transformation, as already discussed before, if the ischemic area is very large. So these patients should be carefully monitored and treated depending at the right time. So again, we need some guidance on when is the right time to introduce anticoagulation in patients with ischemic stroke. What we know and what comes out of the guidelines from the European Stroke Organization is, of course, that there is not easy to make any recommendations on the correct time. There has been a lot of discussions about the right time. What we do know is that bridging with low molecular weight heparin is not recommended, which is a good thing to remember. However, we need to get some guidance on when is the right time to treat these patients. So this is an observational study that was published in 2017, and what seems to be the optimum time for reintroducing treatment between day 5 and day 10. So this is good enough guidance that somewhere along this period of time, the risk is at its lower to reintroduce anticoagulation. Of course, we have the problem with hemorrhagic transformation. So whether there is symptomatic transformation on a controlled CT or not is changing the management. If there is hemorrhagic transformation and large hemorrhagic transformation, then the onset of reintroduction of anticoagulation should be delayed. If there is no hemorrhagic transformation, then the patient should be randomized to a trial if they agree, but still there is no clear guidance on when to reintroduce. What has been done and what we have been also using is this guideline, which roughly says that the patient, if they have a TIA without a lesion on the MRI, or even with a lesion on the MRI, the onset could be, the onset of anticoagulation should be anywhere between 1 and 3 days. And then if they have a mild neurological deficits, and the definition of mild is the NIHSS of 8 or less, it should be done after 3 days. If it's moderate, NIHSS of 8 or 215 should be between 6 and 8 days, or if it's severe, after 12 to 14 days. This is, when discussing with the cardiologist colleagues, they instinctively say that this is actually correct, because this is what usually, the time it usually takes for clots to be formed again in the LA appendage. It takes something like 12 to 14 days before new clots are formed in the LA appendage, so that's how the incidence. So the timing seems to be right. Again, there are ongoing studies for this, many places, and hopefully this dilemma will be sorted out as to be more exact. But this is a good take-home message, the 3, 6, 12 day rule. 1 to 3 if it's TIA, 3, or more than 3 it's the mild, 6 to 8 if it's moderate, and more than 12 if it's severe. Of course, if there is hemorrhagic transformation, again, it has to be more than 14 usually, because it depends on the size of location. Our last case is a case where the patient has both AF but also have existing carotid artery stenosis. So this is the typical very tight carotid stenosis that you can see here. This is the external carotid artery, this is the internal carotid artery. And in these cases, in these patients where you have coexistent atrial fibrillation and carotid stenosis, the difficult part is the management, because carotid stenosis patients will not benefit from only use of anticoagulation. They will need antiplatelets as well. The mechanism here is different, so there is a need for treatment with antiplatelets. So these patients should be offered endarterectomy, open surgery that is, and not angioplasty. And the reason for that is the dual antiplatelet, the need for treatment with dual antiplatelets following angioplasty. Stenting will need dual antiplatelet treatment on top of the oral anticoagulation that should be given for the patient's AF. So these patients should be given the option for endarterectomy, and for these patients offered endarterectomy, bridging with aspirin for a few days following surgery could be offered when the scar has healed and reintroduced NOACs. This is good news because it has cleared the field. There was a lot of discussions and controversy on this area. So, in summary, patients with intracerebral hemorrhage and AF may need prophylaxis with NOACs. They may need left atrial appendage occlusion. Same goes with patients with ischemic stroke. Eventually, left atrial appendage occlusion. This is yet to be seen. Ongoing studies. Please remember the pathway for treating ischemic stroke patients with AF and NOACs. I understand there's been a lot of information in a very short period of time. I'm not sure how we are doing time-wise, Theodoros. So this was my, no, this was my last slide. This is my last slide. So I'm done, and I will be happy to answer any questions if